Hello, OT friends, and welcome to the Uncommon OT series. I'm Patricia Modis, and I'm your host, a Filipino-American, native New Yorker, currently based in Los Angeles, bulldog mama, and an uncommon occupational therapist myself for the past 22 years. On this podcast, you will hear me proudly feature the unique careers of occupational therapy practitioners working in non-traditional and role-emerging practice areas, settings where OT is uncommon. I invite you to receive a dose of OT inspiration, to learn, to think outside of the box, and to be energized and motivated to follow in these unconventional paths. Happy listening! Before we begin this episode, I want to extend a special thanks to Picmonic, our sponsor. If you are an OT or OTA student looking for an excellent learning resource and study aid, Picmonic might be for you. Whether you're studying for your classes or getting ready for the NBCOT exam, it is a visual mnemonic learning tool that has been research proven to increase retention and help students ace their exams. It uses audio-visual learning and intelligence-based repetition algorithms to help with long-term retention while studying. If you're interested in trying it for yourself, sign up today using the link in the show notes or using the code TRANSITIONSOT to score a discount of 20% off your Picmonic membership. Welcome back, OT friends. Today, I am very excited to introduce you to our guest of honor, Louise Berger. Welcome to the podcast, Louise.
Hi, great to be here. Thank you for having me.
You're welcome. Louise is an occupational therapist who specializes in sleep medicine. So thanks so much for being here. I am so excited to dive deeper into your specialty and would love for you to kick us off by maybe telling us a little bit about you, what brought you to OT, and maybe some of your favorite occupations.
Okay, so I live with my husband and two children who are 14 and 11. We enjoy family life. I'm naturally quite an adventurous person, so I love going to theme parks. I love rock climbing. I've done parasailing and, whatever I can do that gives me a little bit of a thrill. Also, I'm just naturally quite a conscientious person. I really love learning. My mind is very restless all of the time, so it's full of ideas of projects and new things I can do, new books I can read. I have to admit, I've got a lot of half-read books. That's a reflection of how my mind is bouncing from one thing to another. And I have a tendency to take on a fair amount of challenges just because that fills me up. But essentially, I just love to see help people to come to a point of enjoying life more and living life more fully. And I find that hugely, hugely fulfilling myself.
Wonderful. Thanks so much for sharing a little bit about you. Can you tell us what inspired you to contribute to the podcast?
It was something that I really wanted to do because I feel that sleep is so important to all of us, and sleep is definitely so important to our patients. Yeah, it's so hard as any healthcare professional, but also as an OT sometimes to know how to address that or what to do about that or whether there's any training. And I just really wanted to help other people think about sleep maybe in a little bit of a different way and to know that there are options out there where they can really make a big impact in their patients, in their clients' lives. Yeah. And you invited me and I was very, very nervous. So it's taken me months to get to this point of recording, but thank you for your patience. I really appreciate it. And I hope this will be useful for other people.
Well, I know it'll definitely be useful for me, so I'm absolutely sure it'll be useful for others. I don't think I've ever worked in any setting or in all of the settings where I've worked. Sleep always came up as an issue, and it sometimes becomes a driving force in terms of folks not being able to conduct their basic ADLs and
absolutely
be in the right mindset. So, I think that there is such a big gap there. And I love that here you are, an occupational therapist out there in the UK, specializing
in this and actually being employed by a sleep clinic. So I'd love for
Mhm.
you to maybe tell us more now about your uncommon OT work and whom you serve and yeah, anything you wish to add.
So I have a few roles. I'll talk about the NHS work first. So anybody who knows the UK health system will know that the vast majority of our healthcare is provided by the National Health Service, NHS, and that's free at the point of access, which makes it quite a different beast maybe to medical care in countries where it's paid for. But I've worked for many years for the hospital that I'm currently employed in. But about 12 years ago, I was invited into the sleep clinic, which at that stage was just providing respiratory sleep services. So mainly assessing and treating sleep apnea. And they needed an insomnia service, having recognized that many patients being referred actually didn't have sleep apnea. They had insomnia, and there wasn't very much they could do to help those individuals. So that's where I came in, and I established the service on only a couple of hours a week. I started with another OT and we shared 6 hours a week to start the service. After about a year, she left. And now we have a much bigger service and we have around 600 new patients every year who we work with multiple times. It's a program that we tend to be offering and have amazing outcomes from that. You know, people whose sleep has completely turned around sometimes after 10, 20, 30 years struggling with
Wow.
their sleep, which is, yeah, it's just brilliant. I feel like it's a real privilege. I don't think there are many other people, many other clinicians, doctors, allied health professionals who are working within the hospital who would be able to say that they see that many people with a chronic condition where actually it's completely turned around after a matter of weeks very often. So it's,
Yeah.
yeah, a really
Well,
wonderful place to be, really.
it absolutely sounds like it. So I want to hear more about that. Whom do you serve? Is this an inpatient unit, outpatient? How do folks get referred to the program? For about how long are typically folks there?
Yeah, so it's an outpatient service, and we see 16-year-olds to as old as whoever might be referred. Generally, we don't tend to get referrals for people in their 90s, but we've certainly had some 88-year-olds, 89-year-olds. And they're people who may be working, but many will have physical conditions, mental health problems. And we bring them in. They have an assessment, which is largely a verbal assessment. However, should we need to, we would be able to bloods or certainly do a respiratory sleep study to rule out sleep apnea or periodic limb movements, for example. And then we're delivering a behavioral intervention. It's called CBT for insomnia, so cognitive behavioral therapy for insomnia. But really, that's a bit of a misnomer because it is very, very different to CBT for anxiety or depression. But it is a non-pharmacological intervention, which is why it gets given that sort of umbrella term of CBT for
Hmm.
insomnia. But it's very based within sleep science and has several components, including psychoeducation, which is going to be teaching people about how sleep works. There's a little bit of sleep hygiene, but anyone will tell you if they have a chronic sleep problem, sleep hygiene is not sufficient. It's about as good as dental hygiene is for treating a cavity. You know, you use it
Yeah.
to keep things in a good place, but you need to do something more if there's a problem. And then
Yeah.
there are a few other very evidence-based components, including sleep scheduling and stimulus control, and then more of the cognitive interventions to help with relaxation and stress management. And that's kind of all a bit of a package and a process that somebody works with. We work with people individually, so
Mhm.
how long they will be under the care of our service really depends on them and their needs. But in a good situation, I'd say that somebody might go from the point of assessment to discharge within 3 to 4 months. And it might be a bit longer if maybe they need a few more sessions or if there are other complexities or just things have improved and sometimes people relapse a little bit, you know, that sort of thing. So
Mhm.
we can adapt it to the needs of the individual, which is a really fantastic thing to be able to do, really.
Wow, I'm fascinated. And as you were describing the different opportunities for interventions, I just couldn't help but think, of course, yes. And how OTs are really well suited for this
Yeah,
assessment process, right?
yeah, yeah,
Um,
definitely.
I'm not sure if you mentioned earlier, but are you the only OT there? I know you mentioned there was another OT at one point, but now you've expanded. Are you
Yep.
the only soldier
So
warrior?
no. So within the Insomnia Service, and admittedly, we are now branching out to providing behavioral sleep medicine to a few other sleep disorders beyond insomnia as well. But either way, within our little team, we're three OTs, although two of us are part-time. And we are within a broader sleep clinic, which largely composes of physiotherapists, so specialist respiratory physiotherapists and respiratory nurses. So the whole sleep clinic is probably a team of about 15, I think.
Ah, I love that you're a strong number in that 15. I want to hear more specifically about, what a typical session might look like. But before we get into that, guess I want our listeners to also learn more about how you transitioned into this role. You've been a practicing OT for some time. I guess, take us back to OT school and sort of the path that you took to get to where you are today.
Yeah, so I've always been quite a busy person. So even before I did my OT training, I did a lot of voluntary work. In particular, I volunteered for one charity for about 10 years, and that was a charity supporting people who had experience of being affected by rape or sexual abuse. And of course, that's a really tough field, but it was a place where I really became far more familiar, had a lot of training, a lot of supervision, a lot of support, a lot of dealing with clients who've, experienced some of the worst things we can possibly imagine, really. And
Mm-hmm.
that sort of really equipped me and gave me an interest in trauma and mental health. I had done a psychology degree already, and I was already working as an OT assistant. Sorry, the moment I came out of my psychology degree, I had a OT assistant job lined up. After the weekend, essentially. And again, with my OT assistant work, I did about a year working in a community hospital doing rehabilitation. But I then went on to work in an acute mental health inpatient unit. So I had that kind of background, then came to being qualified, doing my OT training, qualifying. I got a job at an acute trust in a local acute hospital, which wasn't really where I thought I would particularly fit, but I did want to get a job, obviously.
Mm-hmm.
And did quite a number of different roles and ended up in A&E for quite a long time and really, really loved that, even though I thought it would be the last place I would enjoy, because I'd always imagined I would like rehab and building a relationship, but actually it was
Yeah.
fantastic. And then yeah, I was offered an opportunity really to go into the sleep clinic. The manager of the sleep clinic had approached the OT department asking whether there might be anyone available who could set up an insomnia service. I suspect she probably thought, can we get a doctor? No, can't afford that. Can we get a psychologist? No, can't afford that. I know an OT would be a great alternative.
Yes.
So that is probably why she approached the OT department. But I was really fortunate that my name was put forward and alongside another lady. And yeah, we both jumped at the opportunity and really just haven't stopped since then. The sleep world's quite a small world, but that means that in some ways it's quite a close-knit community, and there's a lot going on there and a lot of change as people's perception
Yeah.
of sleep evolves, and we see it in the media nowadays a lot more than maybe, well, certainly when I started I could barely get any training, but
Yes.
now sleep is really being pushed to the forefront, and I think people are waking up excuse the pun, to the importance of sleep and recognizing that many people are struggling with their sleep and need help.
Yes. I'm definitely waking up. I earlier you talked about the difference between sleep hygiene and actually conducting or having a sort of treatment plan for sleep, right? Because I think that's all I've been doing really as an OT,
Yeah.
or
Yeah.
in the capacity that I've been in. It's just
Yeah.
sleep hygiene, helping them
Yeah.
understand what might
Yeah.
be getting in the way of sleep. And
Yeah.
I love that you're here to tell us more about how we can do more, right? And
Yeah.
really be more specific and
Yeah.
how you do it over there. So, would you mind? This might be a great way for us to kind of dip into that. Can you tell us about a typical day, a typical session, and maybe some goals that you might work on with folks and activities that you do?
Yeah. So a typical day is a lot of client work, which may be face to face, over the phone, or over the internet. A lot of admin. And I chuckle there because, particularly within the NHS, it is quite a bureaucratic area, and we have software which doesn't necessarily support us as we might want to be
Oh,
efficient and productive. MDT meetings, maybe some supervision, auditing, that sort of thing. I mean, a lot of those extra activities aside from the client patient work tend to be
yes.
squeezed into a smaller segment of time. Yeah. And in a typical session, so it's difficult, obviously, because everybody's in a different place. We have these components that we're drawing on, these evidence-based practices, and essentially we're often teaching people about the rationale for the change that we might be suggesting. That change is very much based on the evidence base, but also on a sleep diary, which we have our patients complete pretty much throughout treatment. You know, that sleep diary is a baseline, so we can see where they are. And I do explain to people, you know, almost any other area of medicine, we'd be able to do a scan or a blood test and to get an idea of where this issue is at. But aside from me coming and sitting in your bedroom all night, which you won't like, we need that sleep diary. And then that sleep diary begins to form the backbone of something we can draw on to give tailored recommendations. And furthermore, we can use as a way of identifying when change has happened and, you know, if things are heading in the direction we want. We do quite a lot of behavioral work. So I guess that's one of the areas. I think probably sleep, CBT for insomnia, CBT for sleep is a little bit different to CBT for anxiety, depression. It is more behaviorally orientated. And one of the things we know about insomnia is that a marker of that is a lot of time awake in a night. So it's not that somebody is depriving themselves of the opportunity for sleep. It's actually that their body isn't taking that opportunity in the way that they want it to and need it to in order to feel well. So one of the interventions we use is really, really counterintuitive. Many people who don't sleep well try to compensate for that by lying in or going to bed early. You know, if I need to get in so many hours sleep, then I'm going to go to bed early, give myself the maximum opportunity. But what usually happens is actually all that does is extend the wake time. You know, it's like you've got a pizza dough designed for a 5-inch base and you're trying to stretch it over an 8-inch base. So that person who usually only sleeps 5 hours, but they're in bed for 8 hours, and therefore we end up with gaps. And that person isn't able to sleep for periods of time, which is partly because their body's got stuck in a habit of doing that, and partly because they're feeling quite stressed and worried about sleep. So one of the interventions we use, sleep scheduling, is actually asking people to spend less time in bed, you know, reduce their sleep time in quite a strict way so that their body has to organize the time that it's sleeping efficiently. A bit like if you have a cupboard full of stuff and you downsize your cupboard, you've still got to find an efficient way of fitting all of your belongings into it. And in many ways, this forms one of the key approaches that we're using within insomnia treatment. And it is hard. There's no two ways about it. You take a tired person and tell them you want to keep them awake for longer. They're just like, are you
Yes.
crazy? You do realize I came here wanting to get more sleep and you're telling me to spend less time in bed. But actually, it has a phenomenal impact on people's sleep in a very short period of time. We see within a couple of weeks, so many people are finding that actually their sleep is becoming more consistent and consolidated and predictable. And
Yeah.
with that, they start to build their confidence in their ability to sleep. So the moment they are heading into bed feeling it's okay, I've got this, I'm flaming knackered, of course I'm going to sleep. Actually, their body relaxes, which
Yes.
is really important for sleep. So it's kind of this ongoing process of, that approach alongside other ones, supporting people to get to enough sleep, but sleeping well in that time as well.
The quality, right? And not the
Yeah.
quantity necessarily.
Yeah. We use a lot of metaphors around food, and it's a bit like, if you were training for a marathon, you wouldn't be saying, I need to get loads of food in me. I'm going to have 2 Big Mac meals, not 1 big, because actually there's loads of quantity there, but there's no quality. You'd be better off having a far smaller meal, but making sure maybe a stir fry with some protein and lots of vegetables and nutrients that way. It's going to act as a bit of fuel for you. And that's definitely a first step in sleep treatment, helping people to let go of the worries that they have built up about the amount of sleep they're getting, and to actually get them to focus. It's better for you to have a small amount that's good quality, and then we can build on something that's good. Otherwise, it's like trying to build a house on sand. You need that foundation to be good.
I can hear your mental health OT background really coming into play in this new role of yours.
Yeah, I think that's why sleep excites me so much. And I mean, you said at the start that I'm an OT in sleep medicine, which is how I would describe myself. And just to clarify, I'm not prescribing. Sleep medicine is the field of sleep disorders, the assessment and treatment of sleep disorders. But of course, sleep is affected by everything, how we think and how we feel. And it equally has an impact on those things. And certainly in the field of insomnia, I would say it's probably half of anyone's problem is that their sleep isn't working for whatever reason. But the other half is probably more how they feel about that, how they respond to that, how they cope when they don't have a good day, what it means to them that they can't sleep. So, part of it is the sleep, part of it is the stress about the lack of sleep. And actually, we need to work on both of those areas. But at the same time, we're asking people to do things that are really hard, and getting them on board and helping them to understand the rationale and giving them a sense of hope, but making that realistic, taking small steps towards the goal, breaking it down. They're all really core OT skills that most OTs really have. And sometimes I really do notice when maybe another professional is working in the field of insomnia, sometimes make the mistake of thinking it's a set of rules that you can give a person and you can kind of like drop it from the sky. That would be like dropping the Amazon package from the sky. The delivery mechanism is just as important as what you're delivering, and you can't have one without the other. Yeah, it gets me excited.
I hear you. When you said that, I'm also in a setting where I work with other professionals whose approach just are different because of the holistic way that we're looking at that person, individual system. The approach becomes more holistic. The conversations become more holistic. Identifying the needs, you're looking at the bigger picture, right?
Yeah.
So those are just very automatic things for us occupational therapists.
Yeah.
Okay, so thanks so much for giving us such specific examples of who might be utilizing the service, the types of things that you might cover in, these sessions, some of the goals, and really what you're trying to achieve there. I also love that you shared with us, so now I feel like I have some more vocabulary to take in. I love learning about sleep scheduling, sleep education. I think we do a lot of that. I'm happy to hear that sleep diaries are of benefit for sleep clinics, because if there's one thing that I've also suggested is to just journal about your sleep and
Yeah.
tell us what's going on. If you're up
Yeah.
anyway, just write about it.
Yeah.
The sleep diary is a behavioral technique. And that's actually how I kind of pitch my OT service when
Uh-huh.
it comes to dealing with sleep.
Mm.
I'll say, well, we're the non-medication
Yeah.
option, right?
Yeah.
So if you're
Yeah.
interested in exploring that a
Yeah.
little,
Yeah.
then
Yeah.
come meet with me and we can
Yeah.
talk. And we'll
Yes.
start with a little assessment and
Yeah.
some of that
Yeah. Brilliant.
education.
Yeah. And the irony within sleep, or certainly within insomnia, is that actually all of the guidelines, the American Association of Sleep Medicine, Canadian, it doesn't matter where you look, Australian, UK, NICE guidelines, there are, well, that's our National Institute of Clinical Excellence, all recommend that cognitive behavioral therapy for insomnia should be the first line treatment prior to any medication. Unfortunately, though, there is limited access, there's limited number of people trained in that, there's limited
Yeah.
awareness even that it exists, which means that very often people will go to their doctor and end up with medication, which, you know, it's a bit like it's treating the symptoms. If you've got a leak, it's better to turn off the tap than keep on mopping up the water. And the medication in many ways is a bit like you're trying to mop up the water without getting to the
Yes.
core of the problem. Yeah.
So Louise, how many, I know you're working alongside OTs and also a team of other professionals within the clinic. How many OTs are there in the UK doing this type of work? Have you been able to network and connect with others? I know you're very much into networking and, volunteerism. Can you share with us a little bit more about that aspect of your work? Maybe the non-paid
Yeah.
stuff.
Yeah. In the UK, as far as I'm aware, we are one of only 3 sleep clinics providing an insomnia service in the UK, that's including sleep clinics which are led by respiratory physiologists, psychiatrists, medics, neurologists, psychologists. So there are not many NHS
Mhm.
insomnia clinics based in sleep clinics. I know there are definitely OTs interested in sleep. Many, some have contacted me and reached out, and there are some some OTs doing great work in some of the mental health services or with their specific client group. Whether they're doing CBT for insomnia, for those insomnia patients is not clear to me. I don't know. I'm sure some are, and probably others are doing their best to support their clients with their sleep. You were asking about other roles as well. Yeah, so my other roles are not necessarily with OTs, although they're all really around the sleep field. So I do sleep coaching for Better Up, who are an international coaching company. I also work a day a week for a TechBio company who are developing what will hopefully be one of the first combined prescriptions of a digital therapeutic with medication. And they brought me in to advise on their sleep product, and I was working on the content for the digital sleep therapeutic program. At the moment, that project's on hold. So I'm actually working on a hypertension project. But really, my role is giving them some insights into the thinking of a patient, the experience of a patient, and the behavioral psychology, and how to integrate behavior change science into the design of our digital product in a way that it's actually going to connect with people and influence them and help them to want to use it. Of course, that's the main issue with digital products. Sometimes people don't carry on using them. So I have that role. Also, I'm a trustee for the British Society Pharmacy Sleep Services. So they are trying to advocate for sleep training and awareness and even tackling some sleep problems within the pharmacy, because many people never go to their GP. They just go down to their pharmacy and they're asking for an over-the-counter antihistamine or something else, for their sleep. So the pharmacies are in an amazing place to actually be able to identify those people who need help with their sleep and signpost them in the right direction. Many
Got
people have
it.
undiagnosed sleep disorders like sleep apnea, but they don't realize that. All they realize is that their sleep is horrible and they feel terrible during the day. So they
Yes.
believe it's insomnia, try to treat it with medication, but actually there's this other thing going on in the background which needs itself to be assessed and treated. So, and there's various other things, of course, other little projects and talks and many opportunities.
Oh, I love your commitment and your dedication, and also it's energizing, you're into this, right? You want to learn more about it. You're networking whomever you can, and you're trying to really spread the idea that occupational therapists have a big role within sleep medicine.
Definitely. I'm not sure my husband appreciates my enthusiasm and commitment to work in quite the same way. But no, it's great. There's a lot of avenues to explore, definitely. And I have a lot of interest in, challenging myself to do that in diverse ways.
Yeah, and I love, you're an OT, so I love how you're applying. You can do episodes on some of these other roles that you're just mentioning, because those are also uncommon roles for OTs. Your ability to kind of use your lens in so many different ways. So thanks for sharing about all of that. Can we delve a little bit into money matters? Anything that you'd like to share? How do services get paid for? Who pays for these services? I know you talked about different roles. I'll let you take it away.
So within the NHS, the job is paid, not really the person. So a job is banded. The job is given a pay range and your wage comes in each month. Typically within the NHS, the wages are not particularly high. However, there is a level of benefit from a good pension and knowing that you will always have a job because there's many people who need the NHS services. My other roles, again, they're fixed pay on a fixed salary. The sleep coaching, it's a set payment for the coaching hours that you do. However, I can do as many hours or as few hours as I want to in a week. So that tends to vary.
And those are, specifically the sleep coaching, is that something that insurance covers? Do you ever go that route with any of your services?
Yeah, so I've never really had the time to set myself up privately in that way. I've always been in roles that have a fixed wage and clients come to you. So I know that some people do sleep coaching and they will, have a relationship with the insurance company and can get paid that way, or they can set their own service costs.
Mm-hmm.
But I've never had a need to go into that. I've just been so busy with everything else that's been going up. And sorry, certainly for Better Up there, it's the employers who are signing up for programs with Better Up, and then Better Up are paying their coaches. So I don't have to get involved in any of that, which is a real blessing, not to be thinking about what I set my costs as or how to bring clients in, that sort of thing.
Okay. Well, that's always another avenue to explore in the future, right? And I think,
potentially,
yeah, but certainly you're keeping yourself very, very busy these days with all of the different roles that you already have. Thank you for sharing with us some of that. It always helps just to kind of know, okay, what's the payment structure? I've heard a lot about the NHS from UK fellow OTs. And how limiting some of the salaries there might be. But it also sounds to me like not everyone, or most of the OTs that I know who have spoken about the NHS are there because they find their work to be very meaningful.
Yes, absolutely. Yeah, I think so. It's the patients that make it, really. And there are opportunities within the NHS. It really has. The NHS is what has built me. Without it, I don't think I would be the person I am. I wouldn't be doing the things I am. So just being part of that broad network, which gives you access to work with other services, to know what other people are doing, to go on training. There's a lot that is good about the NHS as well.
But thank you again for sharing I just want to kind of backtrack a little because I'm super curious about it. You talked about kind of conducting an assessment as folks were referred in.
Yeah, so of course, the assessment is the first real contact that you're having with that individual. And the referral that we've received before is not always particularly clear or detailed. One of the most amusing referrals I ever had was says can't sleep. That was from a GP who clearly was a bit pushed for time and used 3 words and sent that with the past medical history. Yeah. So what we have on paper is often literally a couple of lines from, it might be from a doctor, it might be from a mental health OT, in fact, it could be from a pharmacist, wherever the referrals come from. It's not always particularly clear what's going on. So we obviously want to establish what is the nature of this sleep problem. How is that presenting? What does that look like? When did it start? Are there any other factors that the individual can see are triggers? Often, stress is one of those, and often that can be quite a persistent issue that's contributing. And we want to get an idea of how that person is in their physical health, in their mental health. A lot of the time, we are also trying to work out, is this really insomnia? So insomnia is a word that tends to be very overused. It means something quite specific, but many people would use the term insomnia for any sort of sleep dissatisfaction or sleep disruption.
Yeah.
And as I mentioned earlier, actually, sometimes something else is going on, which is causing that person to struggle to fall asleep or to wake a lot. And actually, they assume it's insomnia, but it could be another sleep disorder. So we spend quite a lot of time really trying to get an idea of, is this actually insomnia, or is there maybe some sleep disorder breathing going on here? Could this be periodic limb movements? Is it maybe even a parasomnia? Sometimes it's a little easier to find that out, because if somebody is doing strange things in their sleep or having strange unpleasant experiences, they're usually quite vocal about that. But certainly that is a big starting point. Is this definitely insomnia? And what's caused it? What might be maintaining it? And making a plan, really, which definitely involves explaining to somebody what CBT for insomnia might look like. Because some people do come thinking they're going to be given a prescription, and I'm not a prescriber. I can't prescribe, and certainly all the best practice guidelines say that prescribing shouldn't be used unless you've exhausted other options. So explaining what behavioral treatment is, and of course it only works when somebody uses the recommendations they've been given. So actually there's some element of setting expectations, but also instilling hope that for the vast majority of people, for about 80% of people who go through this process, their sleep will significantly improve.
So again, I remember touching upon some of those things already earlier, and how the OT lens really works well.
Yeah, absolutely.
During that assessment period.
Yeah. And I guess that assessment process doesn't end after that first probably 50-minute conversation, to be honest. At that point, then we give outcome measures, we give sleep diaries, and really, as you go through treatment, you are still assessing. Sometimes when I get somebody's sleep diary, I'm looking at it thinking, this is not an insomnia picture. I can see from this, it's not. There's something else going on here. Or it might be that actually their reaction, how they experience the behavioral treatment, is really out of kilter with how many people experience it, which again may be a little bit of a red flag for, hang on a minute, have we got something wrong here? Is there something else going on here? So that assessment definitely continues through time. Blood tests, sleep studies, that sort of thing, if we need to do them, they're all available to us.
So how do folks get referred to your program? Is there a minimum criteria, duration of lack of sleep, or just what are some of the... Not
really. I mean, the sad reality is that most people come only once they've had years and years of problems. And I think that's a real shame.
Yes.
Theoretically, insomnia disorder is 3 months or longer, but I don't think anyone would dispute the fact that the decision on that being 3 months versus 2.5 months or 4 months or whatever is really quite arbitrary. And in my mind, really, it would be better if we had a healthcare system that could respond to problems before they become really embedded. So actually, I don't really mind. I'd rather help somebody before they get into a terrible place. But typically, many of our patients are referred after years, often decades of difficulties. We're quite broad on our referral criteria, and that's partly because we generally receive our referrals from doctors. But most medical professionals don't know a lot about sleep. You know, sleep is usually additional training that you need to do. I have heard that doctors often only get sort of 2 hours training on sleep in their entire medical degree. And I think you could probably say it's that much or less for OTs, physios, dietitians, you know, psychologists. It's probably fairly similar. So it's difficult for healthcare professionals sometimes to work out what's going on. So we're quite broad. We ideally want somebody who knows that they're heading into a behavioral program and it's going to involve their participation in that. We do ask that people aren't high risk. So if somebody is actively suicidal or psychotic, for example, then we would usually try not to accept those referrals. It is dependent on getting that information at the point of referral to be able to say no to that. We generally don't accept people who have any severe cognitive issues because with a behavioral intervention, somebody has to be able to review what's happened and remember that, and they have to take on board new instructions and implement those. And if maybe somebody has dementia, for example, that's very, very difficult for them to do. Yeah, and we're an adult service, so we go from sort of 16 plus, but I think that's the majority of our criteria, and it's generally other medical professionals referring. So as I say, a lot of GPs, but also a lot of professionals from within our hospital. And also I get referrals from community OTs and pharmacists and other people within mental health. Within the hospital, the tinnitus clinic have become a very big referrer for us, which in some ways isn't a surprise. You know, tinnitus is a really horrible condition to have to live with, but also it's something that I think people often experience quite a lot of distress over. And with sleep and poor sleep, there's a lot of distress there too.
And I love how you mentioned that, because you took the words right out of my brain in terms of, you know, sleep issues, sleep difficulties, sleeping too much. That comes up in so many diagnoses,
Absolutely.
You know, you've talked about tinnitus. I'm thinking about perimenopause, you know, just just so many different ways that it really presents itself, and even with mental health conditions or pain conditions, right? So I'm so happy that you're here to educate us about our relevance in this niche. So far, and just what you've shared about the assessment process, it takes a lens, a very holistic lens, to be able to look at the big picture and how this person's ability to fall asleep is really being impacted.
Absolutely. Yeah, absolutely. And it becomes such a vicious cycle, because the harder it is to sleep, the more somebody wants to sleep, the more worried they become about it, the harder they try, and often then the worse the sleep gets. Not better. You know, it's a little bit like a wet bar of soap. I don't know in the States whether many of you have baths, but in the UK, we actually, a lot of our houses have baths. And I remember sitting in the bath with my sister. We were obviously very young. And, you know, you've got the bar of soap, and it's that game about who can pick up the bar of soap. And if you squeeze it too tightly, it bursts out of your hands. And sleep is very much like that. We do have to hold it lightly. We have to hold it. We can't just ignore it, let it dissolve in the bath. But equally, if we're trying too hard, if we're holding onto it too tightly, then actually it jumps out of our hands.
Yes, that's a beautiful metaphor about this, and really a great way of, a hopeful way of phrasing your ability to be able to manage and improve your sleep habits, right?
Yeah.
So Louise, it's been so helpful, all of this information. I know you mentioned earlier is it a blog or maybe a video that you created, spoke about sort of sleep 101? And can you talk a little bit
Yeah,
about that?
yeah,
And
absolutely.
on that same note, offer any career advice for other practitioners out there who want to explore the specialty a little more.
Absolutely. Yeah. So I created a one-shot podcast. It's 30 minutes, it's free. And essentially it's helping people to understand sleep better and some of the techniques, approaches they can use to improve their sleep. It is targeted at people with insomnia, so a difficulty falling asleep or staying asleep that isn't caused by sleep apnea or sleepwalking or anything else. So I guess I'd put that in there as a caveat. But I created it because it was COVID. We knew that a lot of people's sleep was changing massively. More and more
Yes.
people were talking about their sleep. And I'm just so aware that so many people struggle, yet so few get referrals to our service or a service like it.
Mm-hmm.
I'm not sure why, really. I mean, there's a few reasons I could say, but there are so many people. We know that around 10% of the population have what could be diagnosed of as insomnia, and at least 30% of the population struggle with their sleep. If we look at populations with physical or mental health problems, it's way higher than that. So I wanted to create something that actually anyone could listen to, and it would be totally free, and it would be a combination of something that they would probably have to take quite a long time researching to get all of that information in one concise chunk. And actually, I've been really, really pleased to hear that some people have contacted me, they've emailed in and said this has been so helpful. It's completely turned my sleep around. We've had a few people come to our clinic where their GP had provided them with just this single podcast at the point of referral, and then they come to the first appointment and say, well, actually I feel a bit bad being here because I listened to the podcast and made a few changes, and actually my sleep is so much better. Now, I'm not saying it's a magic wand, and that isn't the case for everyone, but I just really want to get out the word out there that probably what people have believed about their sleep hasn't necessarily been correct, not necessarily helping them. And there are some changes that are relatively simple, not always easy, but definitely simple. And actually, that can really help. And if that doesn't help, then there is something called CBT for insomnia, which can be super helpful in getting people to sleep. And, I want to make people aware that that exists. There is hope, essentially. That was one of the fundamental values of that podcast that I wanted to convey. There is hope. And I've spoken so much about that. I've completely forgotten. Career, what else you asked me? I think it was about career advice. Yeah, so I just think as OTs, we are exposed to so much, and we have a real opportunity to notice how somebody is sleeping, to find out about that, and to be able to support them with that. I think a lot of OTs are trying to do that already, but having gone through this learning process and worked in a sleep clinic, what I realize is before all this, I actually didn't really know that much about sleep and how it works. I think I thought I did, but I really didn't. And I didn't understand how the sleep systems worked, which limited my ability to support patients in understanding what to do. And I really didn't have any awareness about any other sleep disorders. And as I've said, because insomnia, it looks like insomnia, but a lot of the time there's something else going on, another sleep disorder going on. Actually, it's really, really important for us to be able to have an idea on that and discern. So I would say that OTs, like any other profession, even if they're not working in the sleep field, they have an opportunity and even a responsibility, really, to be screening and signposting people in the right direction. And if that's the most somebody can do within their setting and within their knowledge base, That's great. That's brilliant. That's so much more than is happening already.
Yes.
Just knowing the main sleep disorders and how they look, and where you maybe can refer a person to, or where you can recommend they go for further assessment or support in that. But there is a lot of training out there now. As I say, when I started 12 years ago, it didn't feel like there was a lot, but there's a lot more, because sleep really is getting on the agenda. So that would be my other prompt to other OTs. Maybe check out for a sleep medicine course. They're often a couple of days, or a CBT for insomnia course, which again would probably be a couple of days. There's lots out there, and I think it would really equip people and help them to feel more confident, which is definitely an important part of the process.
Such great advice. Thank you so much for all of this info. We'll attach links to these resources so folks can look into them if they're interested. And thanks for providing us with this other free resource where you've pretty much compiled and saved us a lot of time, right?
I hope so.
So, I look forward to listening to it, and was already kind of thinking about maybe organizing a group around it in terms of having folks kind of also understand, the OT's role, right? And how we can assist in this sort of the behavioral intervention. So thank you for that. We're for sure going to post that on our show notes. Now, if our listeners were looking to get in touch, ask a few more questions, and connect, would that be okay if they did? And how do they do so?
Yeah, of course. So probably the best way of getting hold of me is through LinkedIn. I say that slightly tentatively because I'm not sure how many OTs actually use LinkedIn. I could also share an email address that they could email me on if that's helpful. Because I'm not actually having to advertise myself and draw in work. I don't have a web page, and I'm not hugely proactive on social media. But those would be the best methods.
Okay, I think I found you on LinkedIn.
You did, absolutely.
Right?
Yeah, it was after, I posted an article, and you reached out following that. So, yeah.
Yes, so you have a social media presence.
A little bit.
In LinkedIn.
I tend to do a lot of stalking. I'm just really fascinated by what other people are doing and reading their contributions and their articles and things like that, connecting with people where I can. Yeah.
I find myself spending more time on LinkedIn now because it's really hearing from, my OT professional friends who are just posting their work and talking about, so I think it's really extended my reach, and again allowed for me to connect with individuals like you. So thank you so much, Louise, for sharing with us your specialty, sharing with us everything that you know, and really helping us understand how we can also get into the specialty and the need for OTs and the relevance for OTs in this field.
Yeah. And thank you so much, Patricia, for this opportunity and bearing with me through all my ramblings on.
Oh, I love your ramblings. Your ramblings are not ramblings to me. It's information that needs to be shared. So I'm really hoping that some of our listeners, again, will be in touch with you. At the very least, check out the podcast that we will post with the show notes. And I look forward to connecting with you again in the future about some of the other uncommon OT work that you've been up to.
Okay, thank you so much. That'd be great. Yeah.
And that wraps up another inspiring episode of the Uncommon OT series. Connect with me at www.transitionsot.com. And don't forget to sign up to be part of the Transitions OT community. By doing so, you'll receive my latest compiled list of uncommon OT practice settings, the latest news on mentoring offerings, uncommon OT live events, non-traditional OT resources, and more. You may also follow me on my social media pages on Instagram and LinkedIn. And if you love this episode, head on over to Spotify, Stitcher, Apple, and Google Podcasts to follow, rate, and leave a review. I also ask you to consider pledging your support to my Passion Podcast project by being a patron on Patreon. It is very much appreciated. Sending big OT love. Thank you so much for listening. Until next time.